So, good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, and the focus of today's session is NNF Shine Week 4 West Zone. So let's begin today's session, for which I would like to invite Dr. Swetal Bhatt ma'am to take over. Over to you, ma'am. Kindly proceed with the talk.
Thank you, Shreyansi. Thank you so much. Uh, I'll just do the slide screen sharing. Just a minute. Okay. Yeah. Is it visible to all?
Yes, ma'am, it's visible.
Okay. Thank you. Thank you so much. So, good evening, dear all. Myself, I am Dr. Shwetal Bhatt. I'm an associate professor in Baroda Medical College, and I'm a president for NNF Gujarat State. So, today we are having a week 4, and all of you must have gone through the resource material shared by the National Neonatology Forum uh, which is in form of videos, PPT, as well as the PDF. So all of you have gone through that, and we all of you must be practicing developmentally supportive care in your units. So today we will have an overview of that. Any questions we can take up later on. So what is developmentally supportive care, and why do we need to do a developmentally supportive care? So developmentally supportive care is an integrated approach. It compromises.
Ma'am, sorry for the interruption, ma'am. Can you just make it full screen? Your slides are not in slideshow mode.
It's full screen on my laptop.
Okay, but it's not showing.
So what should I do?
Ma'am, you can share once again, unshare and then share once again.
Okay, I'll do the first. Okay, stop sharing. I'll do it.
Yes, yes,
Right? Then,
yes.
uh, so is this okay? Just a minute. Share. Is it okay? Shreyansi,
Yes, 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 ma'am. Yes,
full
perfect.
screen mode?
Yes, yes. Please continue.
Okay, good. So we were at what is developmentally supportive care, how we define it. So you all of you are doing, it's an integrated approach, compromise of set of do's and don'ts in the SNCU, which are potentially benefit to the sick preterm neonates or any neonate who is sick to help them to cope up the adverse external environment of the NICU. Shreyansi, the slides are not moving. Yes. So what are the components of the DSC, developmentally supportive care? We need to protect the sleep of the newborn, the pain and the stress assessment and the management. Every time when we are doing the procedure, we need to assess the pain and we do need to know the management of it. Then developmentally supportive activities of daily living, day to day when we are handling the sick newborn. Family-centered care involving the mother, the relatives in the care of the newborn, which are the ultimate caregivers of the newborn. The baby is with us for a short time. Ultimately, the baby is to be cared by the family. Creating a healing environment. It should not be a stressful environment for the newborn. So let us see one by one this component of the developmentally supportive care. So let us start from the protected sleep. How we can protect the sleep in the NICU and how we can promote that. So once, as you see in the figure, we can do a facilitative tucking, swaddling, nesting, so that the newborn feels very cozy as if the baby is in utero, right? Kangaroo mother care. We all know the benefits of the kangaroo mother care, and we'll take detail. Kangaroo mother care is a multimodal developmentally supportive care. So today only, after the session of the different components of the developmentally supportive care, we'll take kangaroo mother care in a detail. The environment of the NICU, the light, sound levels, which has to be minimized. The day and night pattern has to be stimulated. Minimizing the sound, minimizing the conversations in the round during the rounds, addressing the alarms immediately, and avoiding the cross talk or shout like avoiding the door talks, and like if you the door bangings are happening because of that automatic doors, that we need to avoid. Prevent and treat the pain. So how we can do it? Today in the morning rounds, like once the resident comes, he takes some investigations, then the senior comes, he takes some investigations. The often and often the nursing staff comes, the newborn is getting disturbed, his sleep is not protected. In that in case in instead of that, if we do a clustering of care in the morning, if when the bedding is going on, at that time the entire care of clustering of care is done, and then the baby is allowed to sleep, that will be also help in relieving the pain. Adhesives, immediately just removing the adhesives will be painful to the newborn, so adhesive should be removed only when it is loosened from the skin surface. Their skin is very delicate, right? Parents must be educated regarding the infant pain. Parents must be aware of what is pain in the infant. They are also supposed to be handling very gently. The mothers coming in the SNCU with the bangles may be hurting the baby. So we need to take small, these are very small things, but we need to take care of this part. Unit protocol for documenting the pain and managing the pain has to be there. Like some of the unit have a protocol of giving EBM swabbling while the painful procedures are going. Some of the unit have a pain protocol of managing with the 25% sucrose or dextrose. Different protocols are there. Maintain that protocol, manage, write down, make a policy. Protocols are there, and then adhere to that protocol to prevent the pain in the newborn or minimize the pain. Use of both non-pharmacological and pharmacological measures of pain to pain prior to the painful or a stressful procedure is must. Activities of daily living. Use boundaries to maintain them in a flex posture. As I said in the beginning, newborn, preterm newborn, like they have not completed a term in utero. So let us give the same in utero atmosphere in our NICU. So make a boundaries, nesting, swaddling, gentle handling of the baby. Diaper should be changed very gently without lifting the legs. The non-nutritive sucking, it has an immense benefit in pain management as well as the relieving the stress of the newborn. Non-nutritive sucking means either you just give EBM is available, you can give EBM, or if EBM is not available, in that case, whatever your unit protocol is there with 5% dextrose, how you are managing that you can give for managing the pain of the newborn. Mothers must be encouraged to participate in the baby's care, feeding, application of oil, diaper changing, sponging of the baby, just standing with the baby and cuddling the baby and singing with the baby. These are all activities which helps in relieving the NICU stress of the baby. Family centered care. As we said, there is a lot of promotive activities and promotive evidence are there for the family centered care. And when it came out with the WHO recommendation of family centered care, and when I was going through, I felt like, in fact, in India, we are blessed that we always allow the mother to be with the baby, and we also help engage mother in the care of the baby, maybe because of the shortage of the nursing staff or maybe whatever the reason, but most of the time in our government setup we never prohibited mothers to enter the NICU. So that was one of the good thing which we are already practicing, and we should promote that all the family members who are there, who are taking care of the baby, must be trained for the protocol, how to handle the baby, how to enter and with what measures they are supposed to enter the NICU, and they can be involved for the baby's care in the NICU. So for that, we need to train them for hand washing skills. We need to monitor them for hand washing skills. We need to train for infection prevention also. As I said, coming with the bangles or if they have not taken bath, we need to first counsel the mother before allowing her for the family centered care in the NICU. The protocol for entry to the nursery, they have to wear the cap, mask, gown, depend on your unit protocol. They are supposed to be trained first instead of like, hey, behin, yahan kaise aa gayi? That is not an approach for us, right? We need to be gentle with that mother who is the immediate postpartum mother. And these mothers, believe me, they are excellent. They can provide excellent nursing care if we have counseled them gently, and if we appreciate them, encourage them to take care of their baby. We need to teach them, we need to train them for the developmentally supportive care. So these all skills which we are training are going to pay us when we discharge the tiny newborn at home. They will be following same thing at their home also. Kangaroo mother care, as I said, we will discuss in detail, but it is one of the epitome of developmentally supportive care. We must practice in our NICU, and no baby, according to me, no baby should be deprived from kangaroo mother care. Always prepare parents for the discharge. Prepare them how they will take care at home of their baby, so that they don't end up with the same baby which we have taken lot of care during their NICU stay. The baby comes either in the PICU, or the baby comes immediately after some time in our extra outborn unit. That should not happen. So we should have a proper planned discharge, and parents should be trained for the baby care at home. So this is about the family-centered care. There are so many components of the family-centered care we need to discuss daily with the parents. Now, our NICU environment. Our NICU environment has to be a healing environment. A soft music is going on. There is no shouting. There is no loud conversations. There is no alarm buzzing. That NICU is very, the baby's neurological neuroprotection can be achieved if this type of NICU is there. So how we can do it? We can minimize the sound and light. We can have an odd like we can have the decibel, we have to 40 to 60, more, not more than that. We have to monitor that. Do not use procedure light unnecessarily. Sometimes what happens, like as a resident, we are doing the procedure and just there is a call and we went up. We don't complete the things. How do you complete? The needle has to be in the proper tray. There should not be a light which is on. The things which you have used are supposed to be out of the baby's bed. This I often see in almost, like, because you are too busy as a resident R1, you have lot of work. But yes, you ask nursing staff to be with you and ask them that whatever the things clutter is there has to be removed once the procedure is over. Okay. One day immediate, I'm just like sharing one experience. Like a birth asphyxiated baby was there. The resuscitation call was attended, and the baby was brought to the SNCU, then NICU. Then the baby was kept on ventilator. Everything was fine, right? But how can you leave this in a cradle without a cap on the head of the baby? All of us know that hypothermia can lead to 28% of morbidity. It increases the morbidity, right? The mortality. So we cannot we cannot just doing the procedure and go away. We have to ensure that whatever things are disturbed while doing the procedure, again, they are back to that place. If you have disturbed the nesting, if you have disturbed the position of the baby, it has to be back to the place before completing the procedure. Then only the procedure get complete. So whenever there is a procedure, what I ask, make a checklist. There has to be a checklist for each and everything, and that checklist include the last line: the baby was back to normal developmentally supportive care position after completion of the procedure, which we have to maintain. Do not use procedure light unnecessarily, which is like, even the light has to be, once your procedure over, you have to switch off that, right? Otherwise it is just going on, which is harmful, which is very stressful for the tiny newborn. Practice good caregiving behaviors such as adherence to the infection control protocol. Every unit must have their own infection control protocol, and they must adhere to that. That will have a immense dividend. If you follow this infection control protocol, your babies will be having less sequelae, more neuroprotection, less ventilatory associated pneumonia. And these all things will lead less IV line, less antibiotic, and that will lead to early discharge and intact survival. Any test results that is unlikely to change the management is unnecessary, right? इसका CBC कर, अभी आज CBC की क्या जरूरत है? There is no requirement. So first ask, with this test, am I going to change the management? Daily ask yourself one thing. Today I have done with this baby. Am I going to change my, is this investigation will change my management? then only order the investigation. And once the investigation is ordered, it should not be like that. Today, R1 has done this investigation. Now the R3 is coming. He's asking for some. Cluster that. Yes, madam, we have planned this investigation. Once the round gets over, we will be doing. Or you discussed previous evening that for these babies, these investigations are necessary. Let keep these investigations ready before the round so that proper suggestions and necessary management changes can be done. Each investigations, each IV line, each invasive procedure carries a risk of infection. It has immense pain, which leads to neurodevelopmental disorders in the, they have cognitive delays, and there can be chances of iatrogenic blood loss, which in turn which leads to an unnecessary need of blood transfusion, which has its risk factor. The biggest risk factor which I see for the PCV transfusion is ROP. I'm really very scared of that. I don't want my babies to like because of iatrogenic blood loss, there has to be an the baby requires a PEC cell transfusion. Okay. Promote healthy communication between physicians, nurses, and other professionals. Just a minute. I need to charge my laptop. Just a minute. Okay. Fine. So let us go ahead. So developmentally supportive care is a continuous process, starting at the birth, right? So what is there in starting at the birth? How can we give a developmentally supportive care? Anyone can answer me in the chat box? Is it possible to answer in the chat box? Okay, we'll discuss later on. So developmentally supportive care is a continuous process. It starts from the birth. That means as soon as the baby is delivered, and if the baby is breathing, you will keep the baby on mother's abdomen, right? So that is your first skin to skin contact. And 1 hour first skin to skin, 1 hour skin to skin contact is a developmentally supportive care for the newborn. It has lot many benefits to the mother as well as the baby. Immediately when you keep the baby on mother's abdomen and the baby, you do a delayed cord clamping and start early initiation of breastfeeding, the oxytocin is released, which helps in mother's delivery of placenta as well as prevents postpartum hemorrhage. And this is a first, what I say, it's a fourth stage of labor when you are giving early initiation of breastfeeding. And this fourth stage of labor is immense benefit. It will help in establishment of lactation, right? So this is developmentally supportive care starts immediately after the birth. It reduces the stress, it promotes the growth, it provides much needed stimulation to the developing brain. There are 9 different stages of immediately after the birth, putting the baby on mother's abdomen, and it supports the brain development. So we talked about protected sleep, nesting, swaddling, kangaroo mother care, and clustering of care. We talked about prevention and treatment of pain by non-nutritive sucking, swaddling, containment during the procedure. Healing environment by minimizing the sound, light, maintaining the asepsis, facilitates smooth transition. Activity of daily livings like flex posture, feeding schedules, or involving the family participatory care, involvement of the mother, counseling, lactation support, and educating or training the parents and the nursing staff also. So these are the aspects of developmentally supportive care. As you go, if you review the literature, more and more key performing indicators are coming up with the advantages of developmentally supportive care in the NICU. And that helps in an intact survival. As I said, the kangaroo mother care, right? The kangaroo mother care is the most important multimodal technique of developmentally supportive care. All these five component of DSC, right? You can be achieving that if you keep the baby in kangaroo mother position. Once you keep the baby in kangaroo mother position, have you seen the baby and mother sleeping so nicely, so peacefully? Even if the buzzing environment is there, I have seen so many babies sleeping very nicely in on the mother's chest in a kangaroo mother care position. So you are protecting the sleep, right? Once the baby is on the mother's chest, Baby is like there is the pain relief is excellent. So if any procedure is done, if the baby is in kangaroo mother care, it helps in reducing the pain and prevents the pain. Even the activities of daily living, like keeping the baby in the flex posture during the feeding, if it is done in the kangaroo mother care, it has an immense benefit. And kangaroo mother care supports the family centered care. So let us see what is kangaroo mother care. Kangaroo mother care compromise, here it is written two components. I will say three components. If you go through our topic, our this PDF and PPTs of kangaroo mother care, it is a skin to skin contact. First and foremost, it ensures exclusive breastfeeding. Second thing, and third, it helps in early plant discharge and intact survival. So kangaroo mother care has three components which we need to ensure, and kangaroo mother care is one of the best multimodal technique for developmentally supportive care. So who are the eligible babies? The stable babies less than 2 kg are the high priority for the kangaroo mother care. But all of you know the recent research, immediate KMC, right? So babies who are less than 2.5 kg and they immediately we are giving first 1 hour kangaroo mother care, the skin to skin contact, and then that mother baby duo can be shifted to postnatal ward or in an ICU with the same skin to skin contact, and we can continue kangaroo mother care. The immediate KMC papers are coming up, and they have a immense positive outcome, like decreasing the duration of the NICU stay if you offer immediate kangaroo mother care. So when to start kangaroo mother care, we have already discussed. Those babies who are between 800 to less than 2.5 kg, 1800 to less than 2.5 kg, immediate kangaroo mother can be started, and can be started in the labor room as a first 1 hour skin to skin contact, and the mother baby duo goes together to the KMC wards. Between 1200 to 1800 grammar, once the baby is stabilized. So what do you mean by once the baby is stabilized? Once the baby is stabilized, that means the baby is in the on the CPAP. Baby is on the HHFNC. Baby is just on the IV fluid. Baby is on the only the antibiotic are going on. So these are all the things where baby can be offered kangaroo mother care. Except the baby is on the invasive ventilation. That trials are also going on to provide kangaroo mother care on the ventilatory support. But the proven Cochrane review says that babies who are on the CPAP can be offered kangaroo mother care. And yes, we are practicing in our unit. And regarding the ionotropes, when the ionotropes are you're on the tapering mode of ionotropes and the blood pressure is stable, you can start offering kangaroo mother care to the babies between 1200 to 1800 gram. Those babies who are less than 1200 grammar. Recently, just today evening, we were discussing that our 800 grammar is now stable on CPAP. Let's start kangaroo mother care. So those babies who are less than 1200 grammar, once they are stable, they are not on invasive ventilation, we can definitely start kangaroo mother care for them also. So kangaroo mother care can be offered to all the babies who are on the semi-respiratory support, like who are on the CPAP, HHFNC, IV fluids because of the or minimal enteral nutrition is going on, antibiotic is going on. Otherwise, they are hemodynamically stable. So who can provide kangaroo mother? Kangaroo mother care, as name suggests, it can be provided by the mother, ideally, right? Because it helps in increasing the breastfeeding secretion. And there are many other benefits to the mother and the baby. But however, if you do not have if the mother is in OBS ICU, as I said, today morning only, the mother was in OBS ICU. So I said, okay, let us talk to one of the first near relative who is available around, and the baby is low birth weight, preterm, stable. Let us ask them to train them, counsel them. If they can provide kangaroo mother care, then we can also motivate for the surrogate or the foster kangaroo mother care. Father, aunt, grandmother, anyone can provide kangaroo mother care, but they are supposed to be trained for entering into the NICU with all the protocols. So it should not happen कि सुबह आज father आए थे, फिर शाम को रात को grandmother. Everyone, if even if they are coming, you need to train them. So it is preferable that same mother plus one another relative. If we can maintain this 2%, that will be helping us in providing a proper kangaroo mother care with following the infection control protocol and NICU protocol. The person who is offering kangaroo mother care should not be having any infection. So we are seeing in this picture, the father is providing the kangaroo mother care, the mother is providing the kangaroo mother care. They have also taken care of the privacy aspect, right? The curtains are there. So what are the benefits of the kangaroo mother care? So whatever they depicted in the slide are very less, I say. There are so many benefits. You name the thing and it is providing, the kangaroo mother care is helping us out. So let us see what is that. It reduces the pain and the stress to the mother, to the baby and the mother. If it is, we have seen that if the mother is having episiotomy suture and we ask her to do for the KMC, she herself tell us that, madam, there is less pain, right? So both the components are there. Better bonding between mother and baby. See, to have a preterm or a low birth weight baby is really a it's a shock to the mother, because always like when she has imagined a healthy baby which is shown on the movies and the TVs and the papers, newsprint medias, right? So always a preterm birth is a surprise shock to the mother. So to overcome from them, kangaroo mother care helps in bonding the mother and the baby. If the initially the kangaroo mother care started in Colombia, Bogota, was for reducing the hypothermia. Initially, it was started like that it is a poor man's incubator. But no, it's not a poor man's incubator. It is a care for entire strata of the society who has a low birth weight babies. It helps in reducing the hypothermia. Reducing the hypothermia by skin to skin contact. The baby is with the contact with the mother's skin, and it provides a care for the hypothermia. It reduces the infection. Now you will ask me how it reduces the infection. So what happens when the skin to skin contact happens? There is exchange of flora. So that exchange of flora from baby to the mother, baby's immune system is not that so developed as they are preterm, right? But mother's immune system is very strong. So when there is an exchange of flora, what happens? The healthy flora, the pathogenic flora of the newborn gets transferred to mother's skin, and the mother's immune system begins to produce the antibodies towards that, which are secreted in the breast milk. And this we have all experienced during the COVID time. All of you know, during the COVID time, just first 1 month, we were like whether to put the baby on kangaroo mother care or not. But then the statements, guidelines, and protocols came up. No, we can definitely give kangaroo mother care. And I have lot of mothers I have managed during the COVID times were successfully given kangaroo mother care. And neither the mother nor the baby had developed a fluoride COVID in that case. Okay, so there are many infections which are reduced by offering the kangaroo mother care and the breastfeeding. It promotes the growth. Now, how it promotes the growth? So, kangaroo mother care stimulates five senses, five spatial senses. What are they? Hearing. Mother's heart rate are here, right? It's a music for the baby. Baby was hearing that heart rate when the baby was in utero. He is very familiar to that heart rate, right? Then smell. The smell of the breast milk is there when the baby is in the kangaroo mother care position. Eye to eye contact. You know, there is a beautiful arrangement by the nature. When the baby is born, the vision of the baby is only till mother's face. Only that much vision is there. Baby is able to see mother's face in a black and white format. So vision is stimulated, right? Proprioception is stimulated, right? Then neuronal stimulation is there. So this all helps in the promotion of the neuroprotective as well as the brain growth, brain stimulation, as well as the growth of the baby. When you prevent hypothermia, the weight loss is, you promote the growth. When you prevent infection, you promote the growth. When you prevent pain, you also promote the growth, right? So it is a multimodal stimulation technique. The papers are there. The babies who received kangaroo mother care are better emotionally, better adolescent as well as the adults. Long back in Bogota when it started, there is one paper that those babies who received kangaroo mother care are now adults. So they did that research and they are coming up with a better neurocognitive development when we offer a kangaroo mother care. There are many other advantages which we can keep on discussing, but let's move to the other part. The same thing as we discussed about the benefits of the breastfeeding. We discussed benefit to the mother, benefit to the father, benefit to the beneficiary, that is infant, and benefit to the healthcare provider. Similarly, kangaroo mother care has same advantages. In fact, we have come up with the 10 successful step of kangaroo mother care in 10 steps, as we have come up with the 10 steps of the breastfeeding. So same thing, have a policy, written policy in your NICU about the kangaroo mother care. This helps in mothers' confidence and bonding. They feel less stressed. Mothers are empowered to play a active role in their infant care. A 800 grammer goes home by 1.5 kg. So still this is a low birth weight baby. Mothers are very scared to handle that small tiny newborn. But once they are involved in the NICU, they are offering the kangaroo mother care. They are empowered to take care of their infant. It promotes breastfeeding and there is a less neglect and abandon. For that, I want to share one story to you. Like in my NICU during the COVID days, what happened? The mother was very scared and she just left the baby and she went away. But the father was very mature and he said, okay, fine, she is scared. The father was giving KMC, and in turn, he developed such a great bond that what happened, instead of mother went away, they were like they were the migratory population coming from one state to other state. So we were very scared that they may abandon the baby. But as the father was giving kangaroo mother care, he was so much attached that he gave throughout the period, he gave the KMC. And slowly he started counseling the mother and he could bring back the mother. And the kangaroo mother care was one of the, like the father has given the interview that because of this therapy and I came to know about that and I was like attached to my baby. You have, our marriage was like successful. We could, otherwise we would have got aparted and our baby could have got abandoned. So this social scenarios occurs when we offer kangaroo mother care to the babies. Because as I said, to have a low birth weight baby is really very difficult for the parents to accept and to take care of it. Fathers are able to play a far greater role in care of this, and these are papers are there. There are so many papers about the father's feedback regarding the kangaroo mother care. Recently, we have an IVF twins from Madhya Pradesh coming to Gujarat, especially for NICU care, where the father was like so much dedicated about the kangaroo mother care of the baby that they used to give for 19 hours. Mother get tired, mother want to sleep. The father used to come in the NICU, and we had a really good couple with us and providing kangaroo mother care to their twins. So it improves the bonding between the father and the infant. For the baby, it is warm. It helps in achieving the warmth. It stabilizes the hemodynamically. I have a paper where we have seen that kangaroo mother care, when offered, the heart rate, respiratory rate, and the SpO2 get stabilized. It helps in the hemodynamically stability, improves the mortality. It helps in decreasing the mortality. It infant grow faster. Today only there is one post that 800 grammer going home with 2.18 kg, where the mother and father were dedicatedly giving kangaroo mother care as well as the exclusive breastfeeding. Believe me, kangaroo mother care helps in increasing the hind milk nutrition values. They are able to express the hind milk in a good quantity and help in faster growth of the baby. Serious infections are less, as we discussed, right? There is a entero memory gut access are there, and it helps in decreasing the infection. Less apnea, less use of antibiotic. Apnea can be prevented. Why apnea can be prevented? The mother is having respiration, which is like an apnea meter for the baby. It gives the trust of the stimulation, and babies having less apnea in the kangaroo mother care position. It helps in prevention of the infection. Now, how the healthcare providers are benefited? I always tell my resident and the nursing staff, जल्दी जल्दी kangaroo mother care में ये बच्चा चला जाना चाहिए, ताकि then the entire thing is taken care by the mother. Feeding of the baby, diaper changing, because mother is becoming confident. Less equipments are used. More and more towards the uh, early enteral feed is there. Less IV fluid, less less IV fluid, less antibiotic, less equipment, less infection, right? And if this thing is less, my staff is more towards the very critical baby. And so the survival of the other critical baby we can improve by giving kangaroo mother care to the babies. Infant can be discharged earlier. They are going home earlier. In one of my study, I have documented that early the hospital stay, the days of hospital stay are decreased, right? So 1 day of hospital stay is anywhere around 1500 to 10,000 according to the requirement of the gadgets, right? If I decrease 1 day, my healthcare budget decreases so much, right? So kangaroo mother care, I will never say it is cheaper, it is affordable, and it is in Gujarati, we say it is amulya, priceless. Kangaroo mother care is not cheap. You require training of staff, you require training of mother, you require encouraging the staff, parents, right? So we are spending our time, we are spending our energy for that, right? So, but it is affordable and it is priceless. It is not a poor man incubator. So now what should be the duration? So previously we used to talk about all these things. It's short is for 4 hours a day, extended is five to 8 hours a day, and long is for 9 to 12 hours a day. But now WHOs have come up with a small and sick newborn module where they say that it has to be minimum 8 to 10 hours. You involve the family members, surrogate KMC, but ensure 10 to 8 to 10 hours duration of kangaroo mother care. It is there, right? So we need to ensure that. We need to work for that. Now you will tell me how, madam, we can achieve that. So I have told my resident, okay, morning may in the postnatal wards or in the KMC wards or in the NICU, mothers are waked up, like see in the hospital, we are not able to sleep till 7 and 8 o'clock, right? No mother is going to sleep. So she is up by 6 o'clock. She can complete her daily routine and she can be there available for kangaroo mother care at 6:45 or 7. So the round starts at 9, right? So that 7 to 9 is a time where the mother can give the kangaroo mother care. Then the round or the mother's daily other things are going on. Again 10 to 12. Then some activities there she has to go for pumping or something. The surrogate, the family member can give kangaroo mother care. In that way, you only can design your unit's kangaroo mother care hours for your baby on one-to-one basis. Okay. And one session of kangaroo mother care should minimum last for 60 to 90 minutes, right? To 1.5 hours. Then only the one sleep cycle is completed. Okay, it is scientific. It has a relation with the sleep cycle. And one study you must have gone through that cerebral blood flow gets stabilized when you put a baby on kangaroo mother care. That study is from Karamsar. More and more studies, such studies we require, right? So duration should be counted and cumulative duration of entire 24 hours must be around 8 to 10 hours. And we need to take care. What are we supposed to monitor? That we need to do. But before that, how will you counsel? As I said, we know the principles of communication. GALPAC. What is GALPAC? Greet the mother, greet the parents, then ask them how are they feeling, what are their queries, right? And then listen to that queries. बेन પછી ક્યારે कब कब छुट्टी देने वाले हो, बच्चे को कब मेरा दूध दोगे? They have so many queries, right? So listen to them and praise them. I am really very happy that you have come up this query. You are really very good concerned mother. I really appreciate your queries and concern. We will definitely solve your queries. So praising the mother. And then you advise her. You see, this is the condition of your baby. You should come for the kangaroo mother care. These are the benefits of the kangaroo mother care. You should daily take a bath and come for the kangaroo mother care. Demonstrate them how to wash the hands, how to enter in the NICU, what are the unit protocol, whether the kangaroo mother care gown is available or not, how to wear, where to keep, how to sit, right? Whether there are, as the picture shows, KMC chairs are there or not, right? If the gowns are not available, then they can use their dupatta. Anything. See, don't make a barrier of not availability of this thing. So many aaj nahi diya. Today morning only I had a good chat with my nursing staff. Why didn't you ask the mother? Okay, mother is very sick. Okay. So did you talk to husband? Whether he is able to, he wants to give. Is there a grandmother available? So try to find out. I know it is very difficult to approach them in a big hospital. They are somewhere, but there are now everyone has a mobile phone. And the NICU, you can have one mobile phone of NICU and you call the parents, or you can have a social worker who is calling the parents for and who is with the parents, who is in contact with the parents for asking them to come and counseling, right? So your use of front open dress is available, dupatta is available. Praise the mother once she starts giving kangaroo mother care, her willingness. आप दोगे ना kangaroo mother care? So yes, if she says yes, you praise her and confirm, check the understanding. The Galpec, the last part is check the understanding. See, you check whether she has understood properly or not, whether she knows how to keep the baby in the kangaroo mother care or not. Demonstrate that. Either you demonstrate, ask another mother who is already very good and giving kangaroo mother care. Make a mother support group. Re, Sheila, you are giving very good kangaroo mother care. Can you demonstrate to this mother? So this one in one of my study, I had come with that. It was a qualitative study. So mother has answered. Well, because of the peer group, because of the other mother, I was able to give more hours. We used to talk at night, giving kangaroo mother care to our baby, right? So the mother support group will be very helpful. Demonstrating with the mannequin or a doll or demonstrating on the other mother with her permission will help in checking the will help in like understanding the mother. Mother will be able to understand when you demonstrate to the mother. So what are the requirement of the kangaroo mother care? So kangaroo mother care, I will say ki first and foremost, a willingness of the team. The entire team is willing to give kangaroo mother care. And that team includes right from the in charge of the NICU, professor of the NICU, to the class 4 of the hygiene helper of the NICU. It is not only the nursing staff or not only the mother, but the entire team is speaking one language, and that is the kangaroo mother care has immense benefit, and entire team is working towards that. Then only we can implement. It's not only me, it's not only one resident, it has to be the entire team. Educational material, like in my kangaroo mother care ward, we have those videos which have shared to you. You can share in your KMC ward. There is a television. Continuously, these videos are going on in that ward. There are health talks going on. We have a one nurse educated, so we ask her to take a health talk with the mothers, with the nursing staff working in the ward, and with the also with the father. They take a health education health talk. They show them videos, posters. It is known as comprehensive kangaroo care management package. We have developed a comprehensive package that will show the posters are there, the videos are there, who will give a talk today, who will talk to the mother, who will take the feedback of the mother, that we have to entire plan roles and responsibility of our NICU team. Reclining chair which are washable is a good plastic. Certain companies are the Nilkamal that we can use for in the nursery, right? And some they are really very affording. They can have also a foam, but then the cleaning aspect needs to be checked. If you do not have a reclining chair, then then you have to even the simple plastic chairs also the mothers are happily giving kangaroo mother care, right? In a postnatal ward, they should have a adjustable backrest. Mother's clothing. So if you can afford, yes, we have a similar color gown. So we know this is the low, like mother wearing that gown. That means this baby is a low birth weight baby. So you can have gowns in your hospital. If you don't have, as I said, nothing is a barrier with any clothing, just a dupatta. Simple that lycra t-shirt are also very well accepted by the baby and the mother. They are cotton material and they are really well accepted by the baby and the mother for the kangaroo care position. So any innovative, it has to be, the clothing has to take care of the privacy of the mother and the baby has to be properly positioned. Baby's dressing is very important to have a cap, socks, and the diaper. But we should not have mittens. Okay, this is very much important in the developmentally supportive care. Many nursery pack the baby with the even hand. So these hands are the baby's stress. See, whenever the baby is in stress, he'll bring his hands together. So please don't have the hand coverings. If they don't have mittens, no, they cover with the gauze face. No, It's not required. It is a stress response of the human being to use their hands. And so please keep the baby's hands open. And yes, you can wrap, you can do a swaddling and the hands are inside that swaddle, right? But they doesn't need a, so that the baby is immediately able to cope up with the stress response. So this is this you have already seen in your modules, KMC position, right? Now it is, this picture is long back, almost now, so in 1994, 98 onwards, these pictures we are seeing. See the frog-like position of the baby between the two breasts. So this is a mother. Same thing we can, for grandfather, grandmother, father, you have to achieve this position. So this will allow that the baby is able to see the face of the mother, and the mother is able to see the face of the baby. The head is in the sniffing slight extended position. So there is an eye to eye contact. The nose and the mouth are not covered. The head is turned to one side and the neck is in the straight line. It's not bent. It should not happen like this. Many times we have to tell this preterm small babies, mother has to support the neck, right? The one hand can be at the neck level and the other hand at the bottom level. In this picture, it is shown at the back level. You can just above the, just the neck and the back blending that level, you can keep the hand. Shoulders are flat against the mom and chest to chest with the mom, preferably between the two breasts. Legs are flexed below the breast like a frog-like position and bottom is supported by the other hand. Mother is little upright in a 45 to 30 degrees so that she can see, not flat, and cover the back with the blanket when there is too much cold, but this is a hot season. So simple cotton dupatta will work. We need to take care of the season, right? And both are watching each other or sleeping with each other. So baby is being monitored by the mother as well as the nursing staff. So what are you going to monitor? It's very important. Check the baby every 15 minutes for the first 2 hours while the baby is first time in mother's skin to skin contact, right? Activity has to be checked. If there is an excessive movement, baby is not comfortable, something has to be adjusted. Mother and baby should be in a comfortable position. The breathing of the baby, right? Mother can see the breathing of the baby needs to be monitored. Counting has to be done. Color of the baby, immediately the color has to be pink. Temperature, warmth, temperature has to be monitored, and position of the neck needs to be monitored. So teach mother to monitor ABCT, right? While the baby is in the kangaroo mother care position. That doesn't mean that the nursing staff should not be around. Nursing staff must be there when in the NICU or in the KMC ward when the babies are receiving kangaroo mother care. So what are the discharge criteria? In the last 3 days, the baby has maintained temperature normally. The baby is feeding bipolar or direct breastfeeding and gaining weight of 15 to 20 gram per kg per day in last 3 days. There is no acute problem, no apnea, no vomiting. Mother is confident in taking care. Gestational age is more than 34 weeks and weight is more than 4 kg. These are the discharge criteria, and discharge has to be planned discharge. And before that, minimum 8 hours of KMC for 3 consecutive days needs to be ensured before planning the discharge. So these are the discharge criteria. Discharge you plan one day before and talk to mother about the comprehensive KMC package, how to give KMC at home, who all can give, what are the things to be monitored at home, and when to come for the follow. Such babies, when I'm discharging a baby who is less than 2 kg, I will always ensure कि 3 दिन के बाद एक बार मुझे आके दिखा जाओ. Okay. You cannot have a like that in a full-term baby. Okay, come after 15 days. That we for such babies till they are 2 kg, we ask them for a frequent follow. And so ensure whether they are able to come to your facility or is there a nearby facility where they can be followed up. Because you have taken so much care during the NICU stay, so much gadgets, so much manpower, so much energy we have used, right? And we have got a rewarding that we can discharge them. It's an intact survival. We need to survive this tiny newborn throughout the, it should not be, this newborn should not be landed in the PICU. Like, it should not be that shifting the neonatal mortality to the infant mortality, right? So we need to take a follow-up care of all the tiny newborns. So at home, how mother can promote the KMC? So if mother is working and if she has a good binders, ensure good binder, mother can give KMC during the ambulatory KMC also. But if the mother do not have binders or if she is not confident, it is better that surrogate KMC, that means or a foster KMC by grandmother, father. In Indian culture, always never a mother is alone most of the time. It may happen with the this tech savvy couples who are staying in the some of the like what we say Silicon Valleys where they are alone. But most of the time they have also nanny or granny in their home. So KMC has to be offered, can be offered by anyone. Mother can give ambulatory KMC if proper binders are there so that there is no mishap while doing any work or while the baby or mother should not have any mishap while giving ambulatory KMC. So there are different types of binders available. There are videos of the binders we shared, and any binders can be used. It is not necessary that this blue color, what we are seeing in the picture, which is expensive, that we can use even a just a square cloth. In international KMC conference was there in November, where the Philippines people came up with a very nice square cloth arrangement and binders usage. So that binders we will be showing you in our workshop, which is going to be organized after 6 weeks. Each and every state have different venues of the workshop where we will be able to show you different binders from a simple cloth, how you can create a binder and ensure that you have been demonstrated, or you can raise a query while the workshop is going on that what are the different binders available for the kangaroo mother care. In fact, there has to be a role play. How will you counsel the mother in your workshop? That I will definitely ensure with the coordinators. So as I discussed, follow-up is very important. You have provided so much of your energy, so much of your intelligence, so much of your manoeuvers. You have waked up for these babies entire night. You have done the night duties, and these babies are going home. So they must be taken care for the follow-up also, their anthropometry, breastfeeding, developmentally supportive care in every visit. Then developmental assessment, ROP, very important. A 28-weeker baby, within 2 weeks, the ROP, at 2 weeks, 2 to 3 weeks, the ROP has to be ensured. And otherwise, according to the protocol, 34-weeker, after 4 weeks, we can ensure, we have to ensure according to the protocol of the ROP. Otherwise, there is no mean of discharging, treating this patient or surviving this patient. Because without vision, there is really difficult life, right? So please ensure ROP, and you all, we will take ROP session in detail for all of you, how to prevent. And KMC is one of the preventive measures for ROP. I have seen in my own setup, I have an experience since last 24 years that mothers who are giving exclusive breastfeeding have provided ROP, KMC, their babies have less chances of ROP. Their babies have less chances of infection. Their babies have less chances of PCV transfusion, right? So that we have to ensure this neurosonogram. We have protocol for that, growth monitoring, hearing assessment, immunization, and any other things which require for the babies according to their morbidity. So in summary, kangaroo mother care, breast milk improves the neonatal survival. Kangaroo mother care is one of the best developmentally supportive care. Everyone must ensure early initiation of kangaroo mother care, immediate kangaroo mother care, promotes, improves breastfeeding and prevents hypoglycemia, infection, ROP. Foster KMC is very good option to increase KMC hours. Some of the units are coming up as the KMC volunteers. I really liked it. We have mothers who are donating breast milk for the baby in the CLMC, Comprehensive Lactation Management Unit. Similarly, we can have KMC volunteers. I can give 1 hour to this baby. I'll provide KMC. So we can have the pool of KMC volunteers. Ambulatory KMC with proper binders at home to increase the home KMC hours and increase the weight gain and increase the survival of the baby. Binders are extremely useful when you want to use the ambulatory KMC, and like mother's hands are free. She can work what she wants to do. She can read paper, she can read newspaper, she wants to read book. she can do it. She want to do new knitting, she can do. So binders are really extremely useful when the mother is while giving kangaroo mother care, especially at the home setup. So can there be a barriers to kangaroo mother care? So by now you must have already gone through in your mind, you have done an introspection, no? That what are the barriers in your hospital? Have you done any fishbone analysis, root cause analysis for your hospital? If not, just today, tomorrow only you can go and do the root cause analysis or a fishbone analysis. I have done both the things. I have multiple research on this. To establish kangaroo mother care extended hours, I keep on asking, what are the barriers? Let us remove this barrier. Let us remove these barriers. And such quality improvement initiatives I have done for my hospital setup and community KMC, home KMC. Just before 2 years only, our paper got a good gold medal at NNF. We could do that. Everyone should do this. You go through this paper and go, everyone should. In fact, we have Dr. Sushma Nagya's paper also for home-based KMC, community KMC. So everyone should do that barrier analysis and remove that barrier and offer facility-based KMC as well as home-based KMC. In fact, I want to say even a transport KMC. The baby coming from one hospital to other hospital is very good if you transport in the kangaroo mother care position. Baby going home. We have a drop back facility at our state in Gujarat where there is a khilkhilat, a ambulance. So I have trained the ambulance manpower, ambulance staff that when the baby goes home, it will go in the kangaroo mother care position. I have a lot of beautiful pictures for the transport care. And believe me, the stabilization, hemodynamical stabilization of the babies who are transported in kangaroo mother care position is very, we do not, like if the baby is provided kangaroo mother care during the transport, babies come from 5 hours, 4 hours, Alirajpur distance, and these babies, if they are transported in kangaroo mother care position, they are hemodynamically not that worse as compared to not transported. They are receiving CPAP during the transport. They are receiving oxygen during the transport. So kangaroo care transport is very important. So facility-based KMC, community-based KMC, and transport KMC. This everywhere we can, all the chain. You know, all of you know warm chain, right? Similarly, cold chain, immunization. Similarly, this is known as kangaroo mother care chain. So barrier analysis was done in one of the paper for the QI in Chinese hospital, kangaroo mother care in Chinese hospital. See, so but this paper is from August 2020. We have lot of other QI studies of this barrier analysis. You can go through Indian studies also. Very beautiful. Some of the barriers have come off. Like there was one barrier in our study. बहुत डायपर बहुत बड़ा है ना इसीलिए कंगारू मदर केयर नहीं दे so we started like small diapers available. We checked the availability of small diapers, or we started we customizing the diapers. The large diapers were customized into the small so that the more area is at kangaroo mother care can be given. We also give the kangaroo mother care to the babies who are receiving phototherapy, which help in decreasing the. There is one of the very good paper on that in decreasing the bilirubin level. So here in this paper, it has done that I would have share my paper also. So there are, see, we do a fishbone analysis where place, person, patient, psychosocial environment, process, and the beneficiary is checked. So what are the barriers? Lack of chair. Very easy, 600, 700 rupees. Some patient was very happy. He wanted to donate. I asked, he said, Madam, क्या दूं? मैंने बोला kangaroo mother care chair दे दो. ऐसा करते करते अभी मेरे पास बहुत सारी kangaroo mother care chair हो गई. Even my hospital is ready to give, right? Privacy. So हमने curtains करवा दिए, right? We ensure that the mother's privacy is maintained. Binders are provided, right? Then personals, poor knowledge. So we started counseling the mother as well as the every time new nursing staff is there. So we have started one of the thing Dr. Devrari sir has shared with me that we from the team only one nursing staff who is doing excellent job. We make her a mentor for the other girls. So that motivates them that yes, if I'll do the better work, I'll be also having a badge of the mentor, right? Just giving a badge of the mentor was really empowering them. Then shortage of hospital staff. So in Gujarat, there is a government rule, GR, that each kangaroo mother care ward must have a 6 extra nurses. So that you can, as a policy changes, you can keep that in your state. You can ask to your authorities who are dealing with that. Workload distribution. So we have distributed the work. These three babies are supposed to be looked after by this nursing staff. So distribution of the workload, if you do, then there will be no excuse. What happened before some years? What was happening? The nurses were like, they were not allotted the babies. So what was happening? All nurses is doing every work. Like, चलो सबको एक साथ injection देते थे. चलो सबको एक साथ bedding कर देते, feeding कर देते. No, this should not be there. They were feeling always कि अरे काम का काम ही रह रहा है. इतने सारे 20 बच्चे हैं, 70 बच्चे हैं. In government setup in my NICU, you have 70 babies. So in that, what we divided? We divided. Okay, there are total 12 nurses today. We have 60 babies. Five babies divided. Now each nurse will have to see only 5 babies. They were so relaxed. आज तो 5 baby का काम था, right? So distribute that way. Then comes the patient, sick mother, obs ICU में है mother. तो mother, you have to counsel her कि yeah, your episiotomy pain, I can understand your pain, but once you give KNC, your pain will be relieved. Assist her to come to the ICU, right? Someone can go and call her for the. Then resistance from the family. There was also resistance from the family from in my study. So their training, their counseling, showing them video, their loss of work time. So loss of work time, what can we do? So in that case, we can like ask the father, okay, you can go, we will take care of the mother, you can keep the grandmother over here. So the father is not losing his work hours, right? Similarly, poor support from the management side. वार्ड नहीं दिया था, वार्ड था तो उसकी विंडो टूटी हुई थी. So this management, poor manage support from the management side. Yes, we have slowly developing a rapport and lack of policy. 10 steps of successful breastfeeding. Similarly, we should have 10 steps of successful kangaroo mother care, right? Fear of infection, maternal guilt. उसको लगता था कि अरे बाप रे मेरी वजह से इन्फेक्शन हो जाएगा या फिर बच्चे का गर्दन ठीक नहीं रहेगा. So you can counsel her, right? Then you have to also baby. Baby is on ventilator. Then we are not giving. But baby on CPAP, I can share so many millions of pictures. Baby is on CPAP and we are giving kangaroo mother care. And one just now in I came up with one of the barrier which I was feeling. Oh, is the barrier the that is, madam umbilical line है ना इसलिए kangaroo mother care नहीं दिया. Do why? Umbilical line है तो क्या है? Do it proper dressing and we can give kangaroo mother care. And that gave me really, it was a like research idea for me. So I'm going to come up with a research. Does umbilical cord interfere with the kangaroo mother care? You also can take up that research. We can have multiple papers from our own country, and then that paper can be part of the Cochrane. So more and more research is required. Believe me, small, any all these barriers, take it as a research, and you can overcome as a and do a quality improvement in your event. Phototherapy is not at all a barrier. A beautiful paper has come up, and now more and more research are coming up in the good units about phototherapy and kangaroo mother care. We can give. We are giving breastfeeding while giving phototherapy. All the units are. I'm sure all the units must be giving breastfeeding even if the baby is in phototherapy, right? Similarly, even if the baby is in phototherapy, you can give kangaroo mother care. Kangaroo mother care, there is a big topic which we can discuss, that how it decreases the bilirubin level. So these are the barriers which one by one you take up and you can overcome that barriers. In our my setup, there mother was like very much, madam मुझे kangaroo mother care देना है पर मुझे एक्सप्रेस ब्रेस्ट मिल्क एक्सप्रेस करने में इतना टाइम चला जाता है मैं थक जाती हूँ. So then we thought, okay, we have a CLMC, so we have electric pump. So we asked her, okay, दो तीन बार you go, you will have a, you go and do a pumping instead of doing expression manually, right? So you can find out the alternative. What are the queries, barriers for the mother, and find out the alternative. Similarly, community level barriers. So in community level barriers, lack of facility, lack of linkage. घर यहाँ से हमने डिस्चार्ज कर दिया, फिर हमने उसको आंगनवाड़ी वर्कर के साथ टाई अप नहीं किया, where the mother is staying, and mother is staying in the remotest place of some tribal area, right, where there is a small what I say hut. In that case, if you linkage with the Anganwadi worker, and if she is doing home-based KMC visit, a home-based newborn care visit, she'll be able to support the mother. So that is very much important. We can also tell, अच्छा ठीक है, आप लोग कितने रहते हो? You solve her problem. कि कब सो जाते हैं? When you get a time, how will you maintain the privacy? So talk to the mother that how she can give a home-based KMC. Excessive cold. इतना ज्यादा कोल्ड था कि केएमसी में भी बच्चा ठंडा हो जाता है. सो हाउ विल यू मैनेज, हाउ विल यू कवर, डू दे हैव अ ब्लैंकेट, यू नीड टू टॉक टू देम. इन दिस मंथ, समर मंथ्स, दे कम टू मी, मैडम बहुत ज्यादा पसीना हो जाता है. सो आई सेड ओके, देयर आर फैंस. पसीना होगा तो आपको भी ठंड, अच्छा सा ठंड रहेगा. लेट अस डू समथिंग, नॉट इन द वेरी एक्सेसिव हीट अवर्स, विल नॉट डू इट बिटवीन 12 to 4 in the afternoon. Let us do in the cool hours. So we have started in our setup that okay, morning till 11 o'clock, and then 12 to 4 let the mother sleep, let the baby sleep, and then again when there are cool hours we can give kangaroo mother care. So that we have to talk to the mother what is her barrier, and we can implement. Then training of the staff, training of the field staff. Today only I have talked to my community medicine president of Gujarat, that we can have more community workshops for ensuring home based KMC. घर का काम, मदर को घर का काम होता है, तो वी कैन आस्क her, okay, this is a binder, or if we can engage some NGO to provide binders to this mother, so that they can don't have to spend, and they can give ambulatory KMC. Mother is going for the work, so in our tribal setup, that mother is going for the work. KMC was introduced later, but they used to bind their baby on their chest, and they used to go to farms. So already they know that they can keep the baby in the, but they have to ensure and monitor the baby when the baby are less than 2.5 kg, right? So family support, we need to ensure. If there is some religious belief, we need to clarify. Lack of binder, then engage some NGO, ask your authorities. Lack of water for the bathing, that also very much important thing, so that we need to ensure. And this paper is from rural Sindh, right? We have lot of paper, Indian papers also. So if you want, we can share in the group such quality improvement papers, and you can also implement in your unit. And you can have a aim statement that your unit is practicing kangaroo mother care. Most of the mothers are practicing for 4 hours. I want to reach to 8 to 10 hours. So you can do such analysis, and you can motivate your staff. You can overcome the barriers, and week by week overcoming the barriers, and you can achieve 8 to 10 hours of kangaroo mother care in your unit. Or if there is a, like my unit has a good kangaroo mother care, we are giving 8 to 10 hours, but these mothers when comes for follow up, they are not going at home. So have a community a fishbone analysis, take a cohort of small 10 mothers, ensure all the aspects, and ensure that 10 mothers are giving home-based KMC. Dhire dhire 10 mothers say 20, 20 say all the mothers who are discharged. And your DEIC, you have a district early intervention center or a high-risk clinic. Ensure that these mothers are encouraged during their follow-up visit, appreciated during their follow-up visit for home-based KMC. So let us have a case. I think this case we won't be able to discuss much, but when there is a workshop session, we'll definitely have this case as a role play. So this is a 34-weeker, 2.1 kg, born to a mother, primary mother. The infant is 3 days old. She is on, the baby is on direct breastfeeding. It's an infant SFD baby, right? 1.8 kg. Mother feels she has an inadequate milk production. है ना? This is a very common thing, but the breast is engorged, right? She refuses to express the milk. She don't want to give kangaroo mother care. She is under that. Have you you must have experienced this. Postpartum psychosis may be there. Some postpartum blues may be there, right? The mother has come from far village into a bigger center. She's confused. So there are many other things are there in the mother's psychology, राइट. ग्रैंड मदर इज कंटिन्यूअसली नैगिंग, चलो घर दे, छुट्टी दे दो, छुट्टी दे दो, घर जाना है, घर पे वो खेत में काम बाकी है, घर पे काउ, घर पे हमारी गाय भैंसे हैं. दिस टाइप थिंग्स आर वेरी कॉमन इन गवर्नमेंट एसएनसीयूज, right? We face all these things. Now, how will you manage this? What should be done differently, right? What is the diagnosis of this infant? And how will you counsel the mother? So what I feel that this is not a, like if I can unmute anyone, then we can, if there is an answers, or you can write it in the chat box, your answer. But here we require a proper counseling of the mother and the grandmother. Whatever the social issues are there, that we can sort out. The mother's engorged breast, first of all, we need to treat that. We need to counsel the mother. and ensure the breastfeeding as well as kangaroo mother care. And once this is in 34 weeker 1.8 kg. So if this baby is doing well on the breastfeeding and kangaroo mother care, we can counsel if you provide this and your baby's survival is will be ensured. So once the mother is confident, and then we can discharge a plan discharge with a planned discharge criteria, we should discharge. Otherwise, what will happen? Such scenario we have seen often. They take DAMA, and then baby end up in the PICU with infection, diarrhea in this summer month with hypernatremic dehydration because of inadequate feeding, the cow milk feeding. So it is most important to counsel the mother. And such mothers, when we discharge, we need to linkage them to their local Anganwadi worker or the healthcare providers or the female health worker, so that the rapport building is there in their own language they are explaining, right? So this is very important. Each and every baby matters to us. India is a hub for this low birth weight babies. More and more preterm births are happening, and we need to ensure intact survival of our future generation. Otherwise, I always tell my resident, more and more differently abled population will be increased. So it is our duty for ensuring intact survival, and this developmentally supportive care, a very, very small chain of there is a chain of steps, the do's and don'ts, which if we ensure, if we provide kangaroo mother care, intact survival can be ensured, early discharge and proper growth can be ensured. Thank you so much for patience hearing. Any question from participants? We can unmute. Any questions? I'm not able to, just a minute, okay. Hmm. So in the chat box, there is one, I think, what is that? STS, skin to skin contact. Gayatri has written. Any questions from the participants? You can write it in the chat box. I am very happy, glad to have 39 participants till end. Because this is, see, if you give developmentally supportive care, if you give breastfeeding, if you ensure kangaroo mother care, less and less equipments will be required, gadgets will be required, and more intact survival will be there. And happy atmosphere of the NICU will there. I always talk to my nursing staff. Each death has a negative impact. Each morbidity has a negative impact on the entire team of the NICU. It's not that ke hame kya. That's a negative event and it has a negative impact. So make your NICU a positive atmosphere, happy place by ensuring developmentally supportive care, involving the parents, family, the like smiling mother coming to the NICU, right? And a good teamwork instead of running from the duties. If it is a good teamwork, then and more babies are not on the ventilator, not on the extensive critical care, and the more and more work is taken by the mother, and the relaxed atmosphere of the team will help in an intact survival. So how to tackle problem of inadequate mother's milk and how to discourage formula in this scenario of filling of inadequate mother's milk. So yes, Nikita, yes, a proper counseling with the principles of the GALPAC, right? Here the mother's breast was already engorged, so she require expression of the breast milk. So here in this case, when the breast is engorged, we need to give analgesic to the mother before starting expressing and jumping on the mother. Nikalo, nikalo, right? This type of sentences are really traumatizing them. So, and if you have a CLMC unit, you can send this mother for pumping. And if you do not have, just scold and sponging of the breast, giving analgesic, and gently removing the engorged breast milk will help in further secretion, will relieve the pain of the mother. And hence the baby mother, see, it is the pain which is making her feel कि नहीं करना कुछ मुझे घर चले जाना है, right? Once you relieve the pain, she will be confident enough to feed her baby, right? So the counseling part is very important for this. And discouraging the formula. More and more mothers are minimum 8 to 10 time expression of the milk has to be done for this from for the ensuring proper breastfeeding. So if the expression of the breast milk is done, then as I said, no, 800 gram are going home with 2.1 kg weight, right? With a full mother's own milk without formula. This setup is there very well in a government setup. So if we have to see that if this unit is encouraging mom, why can't my unit? My unit do not have formula. We don't prescribe formula. We don't indent formula. Hospital do not have formula. So when formula is not there, then we have to must. And it is like which mother will feel that okay, bacha bhukha rahega to chale. No. So it is a very gentle counseling the mother will help. Yes, some of the times there are some few cases, rare cases, where we need to take help of milk bank or a CLMC center which is available. If it is not available, in that case, when the mother is in severe postpartum depression or that, in that case, we sometimes we require formula. But in this scenario, counseling was the answer, proper counseling, and showing her, see, there is so much of milk coming out, gently expressing that milk will definitely solve the issue. Giving pacifier during the procedure is good or not? Latika, we don't encourage that. We encourage pacifier in form of non-nutritive sucking. So what is that non-nutritive sucking or EBM swabbling? So that is a small sterile gauze piece is dipped into the EBM, that is a hind milk, which has a good component of taste sugar, and that is given to the baby while the procedure is going on. We don't use pacifier for the procedure. And in fact, in our DSC module also, we don't talk about pacifier. So you can do one of the research. You come up with a small research of 20 babies that are given EBM or dextrose for the and do the procedure and see the pain response NIP score or a PP score, and you'll be or yourself only come up with the answer. We are just now doing one research like giving a vitamin K on mother's abdomen and looking at the pain score. So such small research you can come up with that and you can get your own answers, right? We don't at all prescribe pacifiers. Any questions? So this session was quite long. I'm sure you must have gained some practical aspect. Reena Korean, thank you so much for appreciating my presentation. What's your approach for transition of extreme preterm from oral to gastric feeding to the direct breastfeeding? So orogastric, the word, yes, orogastric. Why orogastric? When I was resident, it was nasogastric, and then the research was there, and it turned to orogastric. So oral gastric tube itself help in chewing and developing the the sucking and swallowing reflux. So once orogastric, we shift to pallade feeding. Once the baby is 34 weeker plus, from the pallade feeding, we shift to baby to the breastfeeding. So it is a gradual transition from orogastric to pallade and to the breastfeeding. Till then, what we used, we empty the breast and allow the mother to use offer the breast so that that empty breast suckling is there and baby suck reflux is developed. It's a very beautiful thing. You can see that videos if I get chance, I'll share it that when you give an empty breast to the this preterm for just suckling, that helps in developing that sucking reflux. And oromotor stimulation, this type of stimulation we do before giving OG feed, OG tube feeding and pallade feeding. So that's simple. If you do it on your own self, once you start doing this type of oral stimulation, your saliva starts secreting, right? And once the smell is there of a good food, your saliva starts secreting. So when the baby is in kangaroo mother care position and if you are giving orogastric feeding, there is a smell, the mother's warmth is there, and the you are stimulating first you are stimulating the oromotor reflex, and then you are giving, and we have established that paper also that oromotor stimulation helps in better shifting from OG tube to pallade and breastfeeding. So that we can definitely do it. Thank you, Neha, for appreciating my presentation. Thank you so much. Any other question? I'm really very happy that all of you are there with me in this session, and you must have gained something. Any questions related to that in your own state group? You can definitely put up that question. And I want to convey that this is a very good program. Your workshop will be there at the end of the 6 week. So around between 26th May to June, first week of June, whatever query are there, try to solve that query with your mentors or the faculties in the workshop and start implementing that. You all are first year resident, most of you. So if you implement this qualitative care of newborn during your 3 years tenure, believe me, your your approach towards newborn, your the previously, अरे यार ये न्यूबॉर्न में एनआईसीयू नहीं करना है, वहां तो बहुत मोर्टालिटी होती है, that entire approach will be changed. Your outcome of the nursery, your atmosphere of the nursery will be changed once you do it evidence based. I always ask my residents, protocol book साथ में रखो, you check whatever मैडम आके बोल गई, मैडम क्यों आके बोल गई, let us check in our book. Okay, so this course is really wonderful. Whatever queries you have, please resolve that query during your first contact session. That will be the on between 26th May to 1st or 2nd June. Thank you so much. Thank you so much for being with me on this Friday evening. We will be now ending the session. Good night.